So basically I'm going to now discuss CGFR in the advanced setting.
Yeah.
Basically it's kind of an overview of how the treatment started and what kind of newer things are happening in the EGFR field. Are my slides visible?
Yes.
So now, as we know that EGFR was one of the first mutation which was identified in lung cancer. It started with the second line setting. Initially, it was used in all comers. Eventually, we learned that yes, there is a mutation called EGFR in which this basically works, though these TKIs were not developed specifically to target that EGFR, but still, eventually we learned that yes, the EGFR is the main target for this TKI. So it all started with then in the second, third line setting, patients who were previously treated. Gefitinib and erlotinib both showed responses. In some sort of patients, they were slightly better in a majority of patients for these pre-treated patients, and it was eventually published that the activating mutation is there in the EGFR, which is actually responsible why these targeted agents work. And eventually that EGFR mutation was identified, based on which there was a response from these TKIs. EGFR is a broad, basically we target the tyrosine kinase part of the EGFR gene, which is exon 18 to 21, most commonly in the 19, exon 19 deletion, followed by 21. And now we are getting more and more of unique mutations because we are doing more and more of targeted or NGS sequencing. All started with IPAS study, basically randomized patients, irrespective of mutation, to gefitinib versus chemotherapy. PFS was not difference in the overall intention to treat population, more or less same. Then eventually we know that EGFR mutation needs to be there. And when we see if patients were divided based on whether they were mutated, then we can see the PFS difference of 3 months, whereas it was not seen that much in the patients who are EGFR wild type. Actually, the gefitinib arm did worse in these patients as it didn't work for these patients. We had more studies from the basically Asian studies, NEG-002, and this Japanese study, which showed more or less the same thing, that PFS in the tune of 10 to 9 months with the gefitinib compared to around 6 months with chemotherapy. So these studies more or less, established gefitinib. Same happened with erlotinib, the optimal in the Eurotrack trial. It showed the PFS ranging from 13 to 9 months compared to 5 months in the chemotherapy arm. So both these studies basically established the first generation TKI, gefitinib and erlotinib as the standard treatment for EGFR mutated lung cancer. Then came the second generation TKI, afatinib. It was similarly studied in EGFR mutated selective population in Lux Lung 3 and similarly Lux Lung 6. Different chemotherapy backbone, and more or less the same thing. PFS was 11 months in the afatinib arm, 5 to 7 months in the chemotherapy arm. OS is not changed, as we know, in all the TKIs, because there are crossover in all the TKI arms, non-TKI arms in all these studies. So OS is not significant, but based on this, we are using TKIs for EGFR mutated lung cancer. This is basically summarizing all these trials. You can see the PFS from the first and the second generation TKI is around 9 to 11 months, and chemo is more or less consistent around 6 months. The OS was not improved in any of the study. Then came the second generation, I'll say the newer second generation TKI, decomatinib. Initially didn't succeeded, then eventually it succeeded in the Archer 1050 study. Basically compared decomatinib versus gefitinib. And you can see the PFS was improved as well as the OS, because there was no crossover in this trial. So OS was also improved. PFS was in the tune of 16.6 versus 11 months, and OS was improved by around 7 months with decomatinib. Adverse events we know are slightly higher. Decomatinib, slightly toxic drug, and majority, almost 2/3 of the patient needed dose reduction. But eventually we saw that even by reducing the dose, the efficacy was not hampered, and we can safely reduce the doses for these patients. So with the use of first generation targeted therapies came the resistance mechanism. We identified different sort of mechanism, and around the most common being the T790M with the new earlier generation drugs. That's why eventually we started with targeting the T790M mutation. Other were also seen by different kind of EGFR mutation and different kind of molecular pathways. but majority were basically targeting the EGFR gene only with the first generation and second generation. So as T790M was the most commonest, so we tried to target that with osimertinib, basically targeting this mutation. AURA3 was a second line study for basically T790M mutated patients compared with chemotherapy, and it showed a PFS of 10 versus 4.5 months. And now then came FLORA study, basically getting osimertinib in the first line. It compared with the first generation TKIs, gefitinib or erlotinib. We have the data, the PFS was improved as well as the OS was improved. The best PFS for 19 months was seen with osimertinib. Adverse events, they are not that much increase, I will say, compared to the other drugs, and one of the most safest TKIs to use, just like gefitinib. So now we start, as the more and more osimertinib was used, the resistance mechanism related to osimertinib was studied. So they were either EGFR dependent. They developed one of the most common mutation was C7S mutation. Not that much common with osimertinib, but seen in around 10 to 15%. But major are off target EGFR. Either they were different pathways activated like MET, HER2, and RAS-PIK3, or there was even small cell transformation or squamous cell transformation in 4 to 5% of the population who were treated with osimertinib upfront. So I see basically the same thing, that EGFR around 10-15% patients, and and 10 to 15 had a change in the histology, and around 10 to 15% have other mutation, most common being the MET mutation. So this is more or less guideline say if patient is progressing on osimertinib, there is no only minor progression, we can continue. If there is oligoprogression, we can consider for local therapy like surgery, SBRT or RFA. If there is a CNS progression only, we can consider SRS and continuing. But if patient has a diffuse progression, we have to change to other systemic therapy. This basically tells what I already told. Histological transformation occurs and off target is basically more common with osimertinib compared to the first or second generation TKIs. So now we started combination therapy. So it started with anti-VEGF therapy, bevacizumab. This NAG026 study combined erlotinib with bevacizumab versus just erlotinib. It showed improvement in the PFS, around 3.5-month PFS improvement, though there was not difference in the overall survival. Similarly, came with this relay study, used ramucirumab instead of bevacizumab. We saw more or less the same data, PFS of around 19 months versus 12 months. Again, the OS was not that much improved. The PFS too was slightly improved with this. Adverse events, yes, are absolutely more. When we use a combination, bleeding events were more common, hypertension was more common, proteinuria was more common, liver-related liver increased ALT, ST were more common when we combined anti-VEGF inhibitor to TKIs. So next came the combination of combining TKIs with chemotherapy. The two study are the TMH study from Luruna et al. And NAG009 study. Both showed improvement in the PFS, slightly better in the NAG study. And our study from India showed improvement in the overall survival, though the other study didn't show a significant benefit, but still there was improvement of around 9 to 10 months. So yes, this is also option for many of the patients who cannot take second, third generation TKIs or other targeted therapy. Combining chemo with the first generation TKI is a good enough option. So recently we got the data for FLORA2 in which they combined upfront osimertinib with chemotherapy. Again, it showed that PFS was improved. It was 25 overall versus 16 months. More improved with patient with CNS metastases. It was almost improved by almost double, I would say 10 to 11 months. Not that much of difference in patients without CNS metastasis. Overall survival is still not reached, or events have still not reached. Adverse events, yes, slightly higher. Grade 3 adverse event, anemia, neutropenia, and thrombocytopenia are more by using combination of chemotherapy with osimertinib. But if we compare with the other, gefitinib arm, the grade 3 adverse events, 3 or more, were lesser in this arm when we compare to the gefitinib chemotherapy study. So now we got some other combination being tried up front. Use of amivantamab, a monoclonal antibody, along with the lazertinib, again the third generation TKI. This Mariposa study in upfront was compared to osimertinib. Again, we saw improvement in the PFS, more or less what we saw with in the FLORA2 study, 24 versus 16 months. And in patients with extracranial PFS was also improved with this combination. Safety wise, more or less, not any significant new adverse events were seen. Yes, skin rashes or skin toxicity was increased because we are using a two kind of EGFR targeted therapies. VTs were not that much increased. It's one of the concern with laser tenib particularly, but they were not that much increased compared, and they were slightly high. Yes, adverse event laser tenib, more VTs were seen, but more or less they could be easily managed. So then came the Mariposa 2 study in the second line setting, patient who has progressed in the first line on osimertinib in EGFR mutated, the patient was randomized to chemotherapy or chemo with amivantamab or amivantamab plus lazertinib with chemotherapy. As you can see, the best arm was the amivantamab, lazertinib and chemotherapy. PFS was 8.3 versus 6.3 versus 4.2 months. So good PS patients who can take all kind of these drugs in the second line setting can be given this option of using a triplet. More or less same was seen in the intracranial. The PFS was 12 months versus 8 months. Safety wise, yes, they are highly related of adverse event, particularly related because of the targeting EGFR, and VT were slightly again higher in the lazertinib arm. So yes, we have to screen for EGFR mutations. We are now getting more and more options. Different kind of drugs, combination permutations are happening. Eventually, we'll get a newer generation of TKIs, but I think the pathway will go to combination and to choosing the correct patient for combination, in whom to give chemotherapy, whom to give just TKI. So we'll, as newer trials are coming, we'll get more and more molecular data, which will help us to define how to properly use these combinations for these EGFR mutated lung cancer. Thank you.
So just want to ask, so what proportion in your OPDs you are using the first generation, second and third generation? The percentage, ijapetinib versus afatinib or dacomatinib versus osimertinib, the usage.
Out of 10 patients, 9 will take the first generation TKI.
Okay. So still the financial issues?
Financial issues the most common. So if I'm giving first generation TKI, I prefer to give along with chemo.
Okay. So definitely you just want to add the scarbopami along with this japetinib. So then pemetrexed will continue in this maintenance or only just japetinib?
With pemetrexed plus pemetrexed maintenance.
Okay, okay. So thank you, Ankur, for this talk. So for